Welcome to episode 97 of Dermatology Weekly. I'm MDedge editor Elizabeth Mishkati. Coming up in the peer-to-peer portion of the program, Dr. Candrice Heath welcomes Dr. Mark Lebwohl from Mount Sinai in New York City. They will be discussing how to counsel patients on biologics during the pandemic. As always, the peer-to-peer portion of the show will be after the news. And in the news this week, we have two stories from the recent Revolutionizing AD Symposium, one on an investigational treatment for AD, a JAK inhibitor, and another on itch triggers in patients with AD. At the meeting, Dr. Eric Simpson presented Phase 3 data showing that baseline surface area involvement, or BSA, was helpful in predicting which patients with moderate to severe atopic dermatitis are more likely to respond to baricitinib. Baricitinib, an oral selective JAK1/JAK2 inhibitor, is approved in Europe for treating moderate to severe AD in adults who are candidates for systemic therapy. In the U.S., it is approved for treating rheumatoid arthritis and is being reviewed at the FDA for the AD indication. Dr. Simpson, professor of dermatology at Oregon Health and Science University in Portland, and his colleagues evaluated which patients benefited most with baricitinib in a Phase 3 monotherapy trial. That study compared 1 milligram and 2 milligram daily doses to placebo in 440 patients. The primary endpoint was Eczema Area and Severity Index 75 at week 16. By tailoring your therapy, you can significantly improve the patient experience, increasing the cost-effectiveness of a therapy, and ensure that only patients who are likely to benefit are exposed to a drug, he said at the meeting. He and his co-investigators established that a BSA of 50% was the optimal cutoff for sensitivity and negative predictive value. About 90% of patients with an EZ75 response were in the group with 10 to 50% of their BSA affected. But among those with a BSA above 50%, the negative predictive value was greater than 90%. In other words, Dr. Simpson explained, there's a 90% chance you're not going to hit that EZ75 at week 16 if your BSA is greater than 50%. They also found that using the EZ75, 38% of patients falling in the BSA 10 to 50% group responded to baricitinib at week 16, compared with 10% of those with the BSA greater than 50%. Due to the rapid onset of response, clinical assessment of patients after 4 to 8 weeks of initiating treatment with 2 milligrams of baricitinib provided a positive feedback to patients who are likely to benefit from long-term therapy, Dr. Simpson said. This analysis, he added, may allow for a precision medicine approach to therapy in patients with moderate to severe AD. In another presentation at the meeting on the challenges of trigger avoidance in patients with AD, Dr. Jonathan Silverberg, Director of Clinical Research in the Department of Dermatology at George Washington University in Washington, D.C., discussed itch triggers. In a recently published dermatology practice-based study of almost 600 adults with AD, he and his colleagues looked at the most common triggers for itch. They found that in the previous week, 65% reported 1 or more itch triggers, and 36% reported 3 or more itch triggers. The two most common were stress in 35% and sweat in 31%, which, he said, was different from what he learned during residency. He said that he was trained that it's all about excess showering, dry air, or cold temperature, which he said are still important triggers. In the study, Dr. Silverberg and colleagues also found that 90% of those who had at least 3 itch triggers reported having 3 months or less of AD remission in the past year. That means that 90% are reporting persistent disease when they have multiple itch triggers, he pointed out. He referred to PROMIS itch triggers, which he said is a simple and feasible checklist to screen for the most common itch triggers in AD in clinical practice. Patients are asked to check off which of the following have caused their itch in the previous 7 days: cold temperature, hot temperature, heat, sweat, tight clothing, fragrances, boredom, talking about itch, stress, weather change, sunlight, humid air, and dry air. It takes less than 1 minute to complete, according to Dr. Silverberg. Additional testing with skin patch and/or prick testing may be warranted to identify allergenic triggers. The study was published in the Annals of Allergy, Asthma, and Immunology. For more on this topic and more stories from the meeting, you can go to the MDedge Dermatology website. And that's it for the news. Coming up, Dr. Candrice Heath and peer-to-peer. Welcome back to Dermatology Weekly. It's time now for Peer-to-Peer. Please welcome Dr. Candrice Heath.
I am Dr. Candrice Heath, guest host for the Dermatology Weekly podcast, and I would like to thank Dr. Mark Lebwohl for joining me on the podcast today for another COVID-related conversation. And today we'll be talking about biologics for psoriasis during the COVID pandemic. And although Dr. Lebwohl really does not even need an introduction, I definitely for formality's sake will tell you about him. He is currently the Dean for Clinical Therapeutics at the Icahn School of Medicine and also Chairman Emeritus of the Mount Sinai Dermatology Department. Welcome, welcome.
Delighted to be here, Candrice. Thank you.
Awesome. So I definitely want to dive right in and just go straight into our topic for the day. So as many dermatologists and healthcare professionals are listening to the podcast, of course, when they hear your name, it is really synonymous with everything psoriasis. So we definitely want to hear from you about some of the official recommendations for caring for patients with psoriasis who are on biologic during this COVID-19 pandemic. What would you like to share with us about that?
Sure. So first of all, let me say there have been several both patient and physician organizations have weighed in on this, and we have a tremendous amount of data considering that this is a virus that's only been with us less than a year. And I'll start at, I think the organization that's been the most active has been the National Psoriasis Foundation. They have a superb task force chaired by Joel Gelfand. I'm a member of the task force, and the task force has been very productive. We have looked at literally every article that has come out on the subject. We've looked at all of the case reports, all of the data, all of every little bit of information about this. The American Academy of Dermatology likewise has a very active task force. SPIN, which is a psoriasis organization based in Europe, has a very active task force. The International Eczema Council, because dupilumab is an important drug in this space as well, has a very active group. Emma Gutman, who's in my department, has been at the forefront of that. And we have an enormous registry here of 5,000 patients. We already have over 3,000 in, and we're basically looking at outcomes in patients with atopic dermatitis and psoriasis who either are on biologics or are controls candidates for biologics that we're comparing. So we have a tremendous amount of data.
And, with that data that you have collected and speaking to your other expert psoriasis colleagues, what do you think are some of the biggest takeaways that dermatologists should know about, being comfortable, or what are the warnings about taking care of patients who are, living in this time of a pandemic, but also have to take biologics to control their psoriatic disease?
Sure. So at the start, I think there was tremendous concern. In fact, I think I was getting up to 600 emails a day or phone calls a day from patients and also from colleagues around the world who said, what do I do with my patient on secukinumab or on, ustekinumab or on TNF blockers or on IL-23 blockers? And I created actually a text that I told my secretary, look, I don't want to see any more of those. Just copy it, paste it, and send it back. We very quickly into it actually had a webcast, which was attended by 4,500 dermatologists.
I was one of them.
Yeah. So, because, it was overwhelming. It was taking up my whole day every day. I think, though, we now have learned a lot. We speculated early on that based on pivotal trial data, that the IL-17 and IL-23 blockers would be safe, and we didn't know if the TNF blockers would be. We also didn't know if ustekinumab would be safe early on. Well, it turns out that based on data from around the world and a lot of data from both Italy, which got hit very hard very early on, and New York, which got hit very hard early on, that being on biologics appeared to not be bad. Now, I will say that there are papers on both sides of this, but when you put all of the cases together, you can't avoid but come up with the following conclusions. And I'll give you some numbers from northern Italy, where they had vast numbers. People with psoriasis or other inflammatory conditions on biologics compared to non-biologics like, methotrexate or low-dose steroids or, 6-MP, the increase in hospitalization was 2.8-fold on the non-biologics. So it looked like the biologics were even protective. If you compared the deaths in those on biologics to a controlled population, comparable control population, it was reduced by 58%. And then the New York numbers, which were the numbers reported were lower, but the same pattern was seen. It appeared that biologics were protective. The largest grouping of biologics was TNF inhibitors. So we were actually wrong early on because we were cautious about the TNF blockers. Well, it turned out that being on TNF blockers were definitely protective. I shouldn't say definitely. This is not a controlled study. It was, registry data, but it did appear that being on any biologics appeared to be protective. I will say psoriasis patients had a drawback. It's just like elderly patients, male patients, skin of color patients are risk factors. Being on biologics appeared to be protective, but psoriasis in general did not, because our patients had some of the risk factors that we identified.
Right, to begin with, right?
Yeah,
those comorbidities.
So we are talking about patients with hypertension, patients who are obese, patients who had a lot of comorbidities that we clearly now know make COVID-19 worse. Dupilumab was very interesting because it treats asthma as well as atopic dermatitis. And it is very clear that having pulmonary disease was a major risk factor. And certainly it's early in our registry here at Mount Sinai, but we have 1,200 dupilumab patients in it. And I can tell you, it looks dramatically like being on dupilumab is protective. So we are seeing that our initial inclination was that biologic therapies are actually not harmful in this setting.
So how does it feel to be at this stage of your career and have something that it's really taken off like this? So the pandemic has really turned a lot of things that we were so comfortable with dealing. And then all of a sudden we had to put our kind of scientific mind back on and be okay with the unknown, and also be okay that, papers that we're publishing right now may not even be accurate, 6 months from now. So how do you feel about that? Sort of the data coming so fast that we take the risk that we may say something that is incorrect.
Right. So I will say, and by the way, you said at the pinnacle of my career, I feel like I'm starting my career. So, and especially with this new dean's job, which has actually been very exciting. We're doing clinical trials across the system in every disease, not just dermatologic disease. But I will say that as soon as I started getting the 300 to 600 emails a day, we did two things. I had a fantastic fellow, Ryan Rivera Ayola, just a real superstar. And what he did, and if he's listening, by the way, Ryan, you better become our resident. If he's listening, so I will say I asked him to collate all of the pivotal trial data from all of the biologics that we had, and a pattern clearly emerged. We submitted it as a letter to the editor, to Jad, because I didn't want to be subject to the rigor of a several week wait to get editorial review, because we wanted it to get published right away. The turnaround, I have to compliment the Jad. They saw the urgency of it. They turned it around in less than 24 hours. We had
wow.
So, and in fact, it was published in less than a week.
Wow.
I have to say that, that's what a journal's for. And Jad needs a lot of compliments on that. They then went on to publish very quickly a lot of the articles on COVID-19 that came out. We also, within a few weeks, we weren't the first to describe skin manifestations, but we published an urticarial rash and a morbilliform rash very quickly at the beginning of the pandemic. And we were energized by that. It was a chance in my career, which is heavily inflammatory skin diseases. We were able to show that we now had a new manifestation of a virus. Mount Sinai, of course, was swamped by this awful virus. We had tents across the street in the park. At a time, we actually took over a nearby hotel. We had that boat sent here, the ship Hope sent here, where we were sending patients to as well. There were beds in our hallways. And I will say, a lot of my staff got the virus. A lot of our residents got the virus. Fortunately, we had no deaths among our staff, but we had 3 deaths among parents and grandparents of staff.
Wow.
So it was a devastating time. Video visits replaced office visits within a couple of weeks. We jumped on every opportunity. We actually, through Foundation for Research and Education Dermatology, we host a couple of meetings. We turned it into virtual meetings every week. We have a fall clinical virtual grand rounds. Well, the first one was that COVID-19 one, and it was to solve a problem. There was no sponsor for it. We simply didn't have, we were getting 600 emails and calls a day, and our colleagues needed to hear, what do we tell our patients?
Right. And so for those listening to our podcast, we definitely have academic dermatologists who listen faithfully. And we have the large majority of dermatologists are in private practice. So of course, if Dr. Mark Lebwohl is your dermatologist and he tells you it's going to be fine, you believe it, right? But what if you are, far away from an academic center, you are, a practicing dermatologist holding it down in your community? What are some things that they can tell their biologic patients so that their biologic patients will be comfortable with continuing treatment?
Yeah, so I think it's actually been a disservice. We had patients coming in who stopped their treatment, and now they're coming back flaring. So there's several drawbacks to that, which we actually pointed out in that first letter. If you come off of a biologic and then you wait for the disease to come back and then you retreat that patient, a lot of the biologics work less well. Some perfect examples, dupilumab, the recapture rate was 83%, which is excellent, but that means 17% don't recapture. So 1 out of 6 patients is going to do poorly. You don't want to stop those drugs if you don't have to. Same with, infliximab was like the worst one, and they actually have studied it and shown that if you stop and restart, a high proportion of patients, and in their study it was 38%, develop antibodies to the drug, so it stops working. So then you have to switch to another one that might not have worked as well as the one you were using before. So there is a lot of downside to stopping and restarting. So whenever we were contacted by patients, we would let them know, you should be treated. A lot of patients are avoiding going to doctor's offices. I would say, the FDA needs to be complimented because they instantly put into place and a lot of the insurers who I fight with all the time should be complimented because they followed the Medicare plan, which was, I thought, excellent. Early on, they said you can get your injections at home, even if they're approved only for in-office use. We'll have it shipped to you. We were teaching patients by video how to give themselves the treatments. That all actually worked pretty well. And I think we saw a lot of things come together very efficiently and effectively to treat our patients. I think still a lot of our patients decided they're going to not take a chance, stop their treatment. It ended up being the wrong decision for many of them.
Right, right. And, right now, one of the hot topics is the COVID-19 vaccine. And now here's another question. because, we have had some recommendations for years about patients who are on biologics and what should we do with vaccines. So are the recommendations different for the COVID-19 vaccine because it's new? What should we tell our patients about that?
So the two vaccines approved just today in the US was one of them, is the Pfizer and the Moderna vaccine was just approved. They're not live viruses. They're nucleotide-based viruses, mRNA viruses, and they pose no danger in terms of live virus warnings. All of the biologics carry a don't take live virus vaccines warnings. These are not that kind of vaccines. You can take them. And the NPF task force has come out with a recommendation that strongly encourages patients on biologics to take those vaccinations and to not interrupt your biologic therapy. And by the way, I'm saying biologic, they've also extended that to apremilast and to tofacitinib, which is approved for psoriatic arthritis, and to methotrexate and the other agents we're taking. Don't take a break from them. Stay on them. They are protecting you against psoriasis. They're protecting your joints. They're reducing the cardiovascular comorbidities associated with the diseases. So stay on them and get the vaccination. That is what the guideline says.
So I think this has definitely provided a lot of information in a quick format, and it's really going to help a lot of our dermatology colleagues. And in closing, do you have any final thoughts that you would like to share with our listening audience?
Yeah, I didn't say one thing I had intended to. So when patients on biologics get infected by COVID-19, what do you do? And the answer is controversial. There are some of my colleagues who say, no, don't stop them. But the package inserts say do. The guidance from the NPF, the COVID task force, is take this on a case-by-case basis. If somebody has horrific disease and they fall apart as soon as you stop their therapy, that would be a different patient than somebody who's stable for months. The package insert does say to stop those drugs during infections. It says it on all of them. And so that's what we've been doing here, unless we're very worried about a particular patient and have a reason to keep them on that therapy. So a patient, for example, with erythrodermic psoriasis, who is barely controlled and falls apart when you adjust downward their treatment, we would probably not stop. We also discourage the use of long-term low-dose steroids for psoriatic arthritis, which I would avoid anyway, but specifically the paper that's coming out from the task force will say, don't do that. It puts your patients at greater risk.
Yes, and that task force paper definitely it's hot off the press, I think within days, and I was really anxious to read those recommendations. So I'm so happy that we have colleagues who have really dedicated their careers to really staying on the cutting edge so that the rest of us can focus on other things in our expert areas and we can lean on each other during times like this. So I would like to say thank you so much again for joining me. I am Dr. Candrice Heath, again, your guest host for the Dermatology Weekly podcast. And I really would like to say thanks again to Dr. Mark Lebwohl for sharing your expertise in biologics, psoriasis, and COVID-19. And everyone who's listening, you all already know this is Dr. Candrice Heath again, signing off as your favorite fun, board-certified dermatologist, your go-to girl for everything healthy hair, skin, and nails. And this has been another COVID conversation with Dr. Candrice. Thank you so much, and I look forward to you listening again.
Thank you, Candrice.
That's it for episode 97 of Dermatology Weekly. The peer-to-peer portion of the show is produced by MDedge editor Melissa Sears and editor Alicia Saunders. All of our podcasts are produced by Nick Andrews and MDedge executive editor Kathy Scarbeck. I'm MDedge editor Elizabeth Mishkati, and this is Dermatology Weekly. The end.